Good morning. Today, we will explore the intricacies of the U.S. healthcare system and its insurance market. This lecture will provide a comparative analysis, using the American model as a lens through which to better understand the strengths, weaknesses, and unique features of Canada's publicly funded, universal healthcare system, often referred to as Medicare. By examining a market-driven approach to healthcare, we can appreciate the fundamental philosophical differences in how health services are financed and delivered. We will discuss key economic concepts such as moral hazard and adverse selection as they manifest in a private insurance market. We will also touch on the economic and social consequences of being uninsured, a situation that is virtually non-existent for medically necessary services in Canada. Our discussion will highlight why the Canada Health Act and its 5 principles are so critical to the Canadian model. The relevance of this topic for Canadian students is paramount, as it provides an international perspective that informs domestic policy debates and professional practice within our own system. We will also review a case scenario to contextualize these concepts in a practical, real-world setting. This will be an academically rigorous and detailed exploration of a complex topic. To begin our detailed comparison, let's firmly establish the foundations of our own Canadian system. The Canadian healthcare model, often referred to as Medicare, is built on a set of core principles that stand in stark contrast to the American market-driven approach. The most fundamental principle is universality and equitable access. All eligible Canadian residents are entitled to receive medically necessary hospital and physician services without direct financial charge at the point of use. This is a critical distinction. The system is funded through general taxation, meaning the cost is spread across the entire population, irrespective of individual health status or income. This creates a massive, national risk pool that is far more stable than any private insurance pool. The Canada Health Act, a federal piece of legislation, acts as the unifying force, setting out the 5 key principles of public administration: comprehensiveness, universality, portability, and accessibility that all provincial and territorial plans must adhere to in order to receive federal funding. This top-down regulation and public administration gives the government significant power in controlling costs and ensuring equity, a stark contrast to the fragmented nature of the U.S. system. Understanding these core tenets is paramount for any Canadian healthcare manager, as it defines the political and economic landscape within which we operate and highlights the philosophical divide between our two nations. Now, let's turn to the U.S. system. It is best described as a complex, multi-payer hybrid model. This is a crucial concept to grasp. It is not a single system but a mosaic of different funding and delivery mechanisms. For the majority of the non-elderly population, health coverage is provided through private insurance, most often through their employer. However, the government plays a significant role through programs like Medicare for those over 65 and Medicaid for the poor and disabled. Veterans and federal employees have their own specific plans. This fragmentation means that there is no single entity with the purchasing power of a Canadian provincial health ministry. This lack of a unified approach leads to vast differences in care, quality, and cost across the country, even across different insurance plans. The absence of a national public health insurance system for all citizens is a fundamental feature that distinguishes the U.S. from virtually every other developed nation. This structural difference has profound economic consequences, leading to high administrative costs, unequal access, and the unique problem of a large uninsured population. This is the central problem that health economists in the U.S. grapple with: how to achieve equitable outcomes in a market-driven environment. This contrasts with Canada, where the central problem is often managing efficiency and wait times within a publicly administered system. One of the most profound and difficult aspects of the U.S. healthcare market is the issue of the uninsured. While the Affordable Care Act has made strides, a significant portion of the population remains without health insurance. This group is not necessarily unemployed. They are often the working poor, individuals in low-wage jobs, part-time workers, or those employed by small businesses that do not offer benefits. Additionally, a large number of people are underinsured, meaning their insurance plan has such high deductibles or co-payments that they still face prohibitive out-of-pocket costs. The economic consequences for these individuals are dire. They are less likely to seek preventative care, often delaying treatment until their condition becomes a medical emergency. This leads to poorer health outcomes and higher costs in the long run. The financial burden is immense, with medical bills being a leading cause of personal bankruptcy in the United States. From a Canadian perspective, this is a foreign concept for medically necessary services. While some Canadians may struggle with the cost of supplemental services like dental care or prescription drugs, they do not face the risk of financial ruin from a sudden heart attack or a cancer diagnosis. The Canadian system, by providing a universal safety net, has effectively eliminated this specific type of economic and health inequity, a major policy achievement that we sometimes take for granted. Moral hazard is a classic economic concept that is highly relevant to both the U.S. and Canadian healthcare systems. It arises when individuals, once insured, consume more healthcare services than they would if they had to pay the full cost themselves. From an economic standpoint, the purchase of insurance lowers the effective price of care to the consumer. For example, if a doctor's visit costs $100 but a patient's copay is only $20, the patient will face a reduced financial barrier and may therefore seek care more frequently. This is not necessarily irrational behavior, it is a rational response to price signals. The problem for the system is that it can lead to overutilization and unsustainable cost growth. In the U.S. private insurance market, mechanisms like copays, deductibles, and coinsurance are used to try and curb this behavior by exposing the consumer to some of the cost. In Canada, moral hazard also exists, as patients face a $0 cost at the point of service for medically necessary care. However, we manage it differently. Our system relies on supply-side controls, such as limiting the number of doctors, capitation funding for some providers, and global budgets for hospitals. This means the supply of care, rather than the price, is the primary mechanism for controlling costs. This is a fundamental difference in policy philosophy. The U.S. uses a market-based tool, price, to manage demand, while Canada uses a centrally planned tool, supply, to manage it. This is a vital distinction for understanding the economic workings of both systems. Adverse selection is another critical market failure, particularly prevalent in the U.S. private insurance market. It stems from the fact that individuals know more about their own health status than an insurance company can. This is a classic case of asymmetric information. Individuals who know they are at a higher risk of needing medical care, for example, those with a chronic illness, are more likely to purchase a comprehensive health plan. Conversely, young, healthy individuals, who perceive themselves as low risk, may choose to forego insurance if the premiums are high, believing it's not worth the cost. This creates a risk pool that is disproportionately composed of sicker individuals, which drives up the average cost of claims. To cover these costs, the insurance company must raise its premiums for the next cycle. This further discourages the remaining healthy individuals from staying in the plan, leading to a vicious cycle known as an insurance death spiral. The Affordable Care Act attempted to mitigate this with an individual mandate to force healthy people into the risk pool, but it has faced significant challenges. In Canada, our public system completely avoids this problem. By covering the entire population automatically through taxation, we create the ultimate risk pool. The costs are shared by everyone, regardless of their health status, which prevents a death spiral and ensures a stable, equitable system for funding core health services. This is a key reason why Canada's approach is more stable from a risk management perspective. One of the most significant economic differences between the two systems is the level of administrative overhead. Due to its fragmented, multi-payer structure, the U.S. system is incredibly complex to administer. Each provider must deal with a multitude of different insurance companies, each with its own set of billing codes, reimbursement rules, and bureaucratic processes. This means that a large portion of healthcare spending is not going towards patient care, but towards billing, coding, and negotiating with insurers. Some estimates suggest that the U.S. has administrative costs that are 3 times higher per capita than Canada's. In Canada, our single-payer system, where the government is the sole funder of core services, dramatically streamlines this process. Doctors and hospitals primarily bill a single entity, the provincial health ministry. This simplifies the administrative burden for providers, allowing them to focus more on patient care and less on paperwork. The administrative savings realized by our system can then be reinvested into frontline healthcare services, technology, or capital projects. This difference highlights a fundamental trade-off. The U.S. system, with its market-based competition, may have more choice, but it pays a high price in administrative inefficiency. Our Canadian system, by centralizing administration, gains significant efficiency and cost savings, which is a major benefit of our model. The cost of prescription drugs is a major driver of healthcare spending in both countries, but the economic mechanisms at play are vastly different. In the United States, drug prices are largely set by pharmaceutical companies and are negotiated with private insurers. There is no single entity with the purchasing power to negotiate prices for the entire population, leading to some of the highest drug prices in the world. This places a significant burden on both patients and the healthcare system as a whole. In Canada, while prescription drugs are not universally covered under our provincial health plans, we have a federal body, the Patented Medicine Prices Review Board, PMPRB, that regulates the prices of patented medicines. This gives the government, and provincial formulary committees, significant leverage in negotiating lower prices than in the U.S. Additionally, provincial drug plans, which cover certain populations and services, act as a large purchaser. This is a prime example of how government intervention in Canada can curb costs in a way that is not possible in the U.S. system. The ongoing debate in Canada is about whether to expand our system to a full-fledged national pharmacare program, which would provide universal coverage for prescription drugs and give the government even greater negotiating power. This would be a major step towards extending the principles of our public system to a service that is currently a mix of public and private coverage. The contrast here is clear. The U.S. relies on a competitive market to set drug prices, while Canada uses public regulation and large-scale purchasing to control costs and ensure a degree of affordability. Let's apply the basic economic principles of supply and demand to our comparative analysis. In a normal market, price is a key signal that balances supply and demand. However, in healthcare, this relationship is distorted by insurance. The presence of insurance, as we've discussed, lowers the effective price to the consumer, which shifts the demand curve outwards, leading to increased demand. This is why a person with health insurance is more likely to go to the doctor than a person without. From the supply side, the number of physicians, nurses, and hospital beds is not infinitely elastic. Both the U.S. and Canada face supply constraints due to the long training and certification periods for healthcare professionals. However, the mechanism for managing supply is different. In Canada, our provincial governments control the supply through budgets and by setting the number of training slots for medical school. The goal is to match supply to the needs of the population. In the U.S., the supply is more market-driven. The number of doctors and hospitals is determined by a mix of market forces, professional organizations, and regulations. This can lead to an oversupply in some areas and a shortage in others, leading to geographic inequities. The key takeaway is that both systems face the same fundamental economic challenge: how to balance demand for services with a limited supply, but they use different mechanisms to solve it. Canada uses central planning and supply-side controls, while the U.S. relies on a more decentralized market approach. A central paradox of the U.S. healthcare system, and a key point of comparison, is its relationship between spending and outcomes. The United States spends a higher percentage of its GDP on healthcare than any other developed nation, and its per capita spending is significantly higher than Canada's. From a purely economic standpoint, this should translate into better health outcomes. However, the data does not bear this out. The U.S. consistently lags behind other high-income countries, including Canada, on a number of key health indicators, such as life expectancy and infant mortality rates. This suggests that the American system is not as effective at converting its vast financial resources into positive health outcomes for its population. The unequal distribution of care, driven by insurance status and income, is a major contributing factor. In Canada, While our system is not without its flaws, such as wait times, our universal access model ensures that everyone has a chance to receive care, which leads to more equitable health outcomes. This comparative analysis demonstrates a critical point in health economics. The simple amount of money spent on a system does not guarantee efficiency or equity. The structure of the system, and how it allocates resources, is far more important in determining a nation's health outcomes. The U.S. system, for all its market-driven innovation, is failing to achieve equitable health outcomes for its population. The single-payer model is the defining economic advantage of the Canadian healthcare system. When the government is the sole purchaser of medically necessary services, it gains immense negotiating leverage. This allows provincial health ministries to bargain for lower prices on prescription drugs, medical equipment, and other supplies. The U.S. system, with its thousands of private insurers, lacks this centralized purchasing power. The single-payer model also simplifies the administrative process dramatically. Instead of providers having to navigate a complex web of different insurance companies, they bill a single entity. This eliminates a significant portion of the administrative overhead that plagues the U.S. system, freeing up resources to be used for patient care. Perhaps most importantly, the single-payer model is the mechanism that ensures equitable access. Because everyone is in the same system, the rich and the poor, the healthy and the sick, all have access to the same level of care, and their ability to pay is not a factor. This creates a system that is not only more efficient but also aligns with Canadian social values. While our system may be criticized for issues like wait times, the single-payer model is an economically powerful tool for controlling costs and ensuring equity. It is a fundamental difference that highlights our nation's commitment to healthcare as a public good, not a private commodity. Let's clarify the role of the private sector in both systems, as this is a common point of misunderstanding. In the U.S., the private sector is the engine of the healthcare market. Private insurance companies, private hospitals, and private clinics are the dominant players. Competition among these entities is believed to drive innovation, improve efficiency, and give consumers more choice. The government's role is largely to regulate this market and to provide a safety net for specific populations. In Canada, the private sector's role is much more limited and is largely supplemental to the public system. While many hospitals are run by private boards and physicians operate private practices, they are paid by the government for medically necessary services. The private sector's main role is to provide services not covered by the public system, such as dental care, physiotherapy, or prescription drugs. This creates a different dynamic. The Canadian public system sets the rules, and the private sector must adapt to them. This ensures that the public interest in universal access is protected. The two systems have fundamentally different philosophies about the role of the government. The U.S. sees the government as a last resort, a safety net, while Canada sees it as the primary steward of the healthcare system. The U.S. relies on market forces to achieve efficiency and innovation, while Canada relies on public administration and policy to achieve equity and cost control. Let's compare the financial architecture of the two systems. In the U.S., money flows from a multitude of sources: employers, private insurance, individuals, and different government programs, to a vast network of providers. This creates a highly complex system of billing, coding, and reimbursement. A single patient's visit might generate multiple bills and require extensive paperwork to be processed. This is a major source of the high administrative costs we've discussed. In Canada, the financial flow is much more direct and streamlined. The government collects taxes, and those taxes are then used to pay hospitals through global budgets and physicians through fee schedules. The patient's financial role in this transaction is minimal. This simplified system eliminates the need for a complex billing bureaucracy, which is a major source of economic inefficiency in the U.S. From an economic standpoint, the Canadian system is a model of a single-payer financial architecture, while the U.S. system is a model of a multi-payer architecture. The Canadian system, by centralizing the flow of money, gains significant efficiency and cost savings, which can be reinvested into patient care. This is a crucial distinction that highlights the different economic philosophies at play. When we look at how providers are paid, we see another fundamental difference. In Canada, Most hospitals are funded through global budgets. This means a hospital receives a set amount of money from the provincial government for the year, regardless of the number of patients they see or the services they provide. This model incentivizes hospitals to be more efficient and to manage their resources carefully, as any overspending comes out of their own pocket. It is a powerful tool for controlling costs from the supply side. The U.S. system, while having some managed care models, still heavily relies on a fee-for-service model. In this model, hospitals are paid for each service they provide. This can create a perverse incentive for providers to deliver more services, even if they are not medically necessary, to increase their revenue. This is a major driver of cost growth and overutilization in the U.S. The debate over which model is better is complex. The global budget model in Canada can lead to long wait times for non-emergency procedures, as hospitals have no financial incentive to increase their patient volume. The U.S. fee-for-service model, while leading to high costs, may also lead to a greater supply of services and shorter wait times. This is a classic economic trade-off between equity, efficiency, and access. It is a critical distinction that highlights the different approaches to provider incentives and cost control. In the U.S. private insurance market, high-deductible health plans have become increasingly common. A deductible is the amount of money a patient must pay out of their own pocket before their insurance coverage kicks in. These plans are designed with a specific economic purpose: to reduce moral hazard by forcing consumers to be more cost-conscious. The theory is that if a patient has to pay the first $5,000 of their medical care, they will be more prudent in their choices. However, the economic consequences of this model are significant. For many low and middle-income Americans, a high deductible is a major financial barrier to care. A patient with a chronic illness may delay seeking care, skip a specialist visit, or not fill a prescription because they cannot afford the out-of-pocket cost. This can lead to a preventable medical crisis down the road. This is a form of rationing, but it is rationing by price, not by wait times or administrative rules. In Canada, our system is often said to ration by wait times for certain elective procedures. The U.S. system rations by price, which can disproportionately affect low-income populations. The high-deductible plan is a powerful illustration of the market-driven approach, where the price signal is used to control demand, and it highlights a major point of inequity that is largely absent in the Canadian system for medically necessary services. This is a critical discussion point in health economics. One area where the U.S. system is often seen as having an economic advantage is in its speed of technology adoption and innovation. The competitive, market-driven environment incentivizes private hospitals and providers to invest in the latest technologies to track patients and gain a competitive edge. This can lead to faster access to cutting-edge medical devices and procedures for those who can afford them. In Canada, the adoption of new technology is a more deliberate and centralized process. Before a new drug or medical device can be widely adopted, it must be approved and funded by provincial health ministries. This often involves a rigorous cost-effectiveness analysis to determine if the benefit of the new technology is worth the cost. This public process, while slower, ensures that new technologies are not just effective, but also a good value for public dollars. This is a fundamental trade-off. The U.S. system sacrifices some degree of cost control for speed and innovation, while the Canadian system prioritizes fiscal prudence and equitable access over being the first to adopt a new technology. A Canadian student must understand this trade-off, as it is at the heart of the policy debates in both countries. It is a key reason why Canada's system can be seen as less innovative but more fiscally sustainable and equitable. Let's broaden our perspective to include public health and prevention. The U.S. healthcare system, driven by a fee-for-service model, is heavily focused on reactive, high-cost acute care. Providers are paid for treating sickness, not for preventing it. This can lead to a system that is very good at dealing with medical emergencies, but is less effective at promoting population-level health. The U.S. also lacks a unified, national public health infrastructure, which became a major issue during the COVID-19 pandemic. In Canada, our public system provides a stronger foundation for public health and prevention. While our system is still largely based on reactive care, The public administration allows for better coordination and funding for public health initiatives, such as vaccination campaigns, disease screening, and health promotion programs. A healthy population is a more productive population, and a focus on prevention can lead to significant long-term cost savings for the healthcare system as a whole. The Canadian system's ability to coordinate these efforts is a major advantage over the fragmented U.S. system. This is an economic principle on a grand scale. Investing in prevention is more cost-effective than simply treating illness after it has occurred. This is a key reason why Canada's health outcomes, despite lower spending, are more equitable than those in the U.S. It highlights the difference between a system designed to treat the individual and a system designed to promote the health of the entire population. The U.S. healthcare system can be thought of as a vast medical industrial complex, a term that highlights the powerful economic forces at play. This complex includes a massive network of private insurers, pharmaceutical companies, medical device manufacturers, and for-profit hospital chains, all of which are major corporations with a vested interest in the status quo. These entities have powerful lobbying arms that can influence policy decisions and pricing, making it very difficult to enact meaningful reform. This is a major economic and political obstacle to change. In Canada, while we have our own powerful interest groups, the dynamic is different. The public system, with its single-payer model, acts as a counterbalance to these forces. The government, as the largest purchaser of healthcare services, has significant leverage to negotiate with pharmaceutical companies and medical equipment manufacturers. The public interest, in theory, is what guides policy decisions, not corporate profit. This is a key difference in the political economy of healthcare. The U.S. system is a marketplace where powerful interests compete for a share of the pie, while the Canadian system is a public good where the government tries to manage the pie in the public interest. This is a crucial distinction for understanding why our reform is so difficult in the U.S. and why our system, for all its challenges, remains more stable and equitable. The economic role of the patient is another key difference between the two systems. In the U.S., the patient is often viewed as a consumer in a competitive marketplace. They are expected to navigate a complex system of insurance plans, compare prices for procedures, and make informed choices about their care. This places a significant burden on the individual and assumes a level of health literacy and information that is often not present. The Canadian system, on the other hand, views the patient as a citizen with a right to care. The system assumes that the patient is not a perfect economic agent and that there is a significant information asymmetry between a patient and their doctor. The system is designed to remove the patient from the financial transaction, allowing them to focus on their health. This is a major philosophical and economic difference. The U.S. system places a great deal of trust in market signals and individual choice, while the Canadian system places its trust in public administration and professional judgment. This is a crucial point for a Canadian student to understand, as it defines the expectations and responsibilities of both the patient and the provider. The Canadian system is not perfect, but it is designed to protect the patient from the complex and often unforgiving forces of the market, a key value of our national identity. A harsh reality of health economics is that all healthcare systems must ration care because resources are finite. The question is not if we ration, but how. The U.S. system rations primarily by price. If a person cannot afford a service, or their insurance plan does not cover it, they simply do not receive it. This is a form of rationing by financial ability, which can lead to significant inequities and poor health outcomes for low-income populations. The Canadian system, on the other hand, is often said to ration by wait times. Because access is universal and not dependent on ability to pay, demand for certain services, particularly elective surgeries, can exceed supply, leading to long wait lists. This is a major point of criticism of our system. However, the Canadian system also uses a more deliberate form of rationing through a process known as cost-effectiveness analysis. Before a new drug or technology is funded, it is evaluated to ensure it provides a good value for the money. This ensures that public dollars are spent in a way that provides the greatest benefit to the largest number of people. This is an ethical and economic choice. The U.S. system leaves rationing to the market, while the Canadian system uses public policy to make these difficult decisions. Understanding this trade-off is crucial for any health economic student, as it goes to the heart of what a society values. Fiscal sustainability is a major concern for all healthcare systems, and both the U.S. and Canada face significant challenges from an aging population, the rising cost of new technologies, and the increasing prevalence of chronic diseases. However, the economic mechanisms for managing these costs are very different. In Canada, because our system is funded through taxation and administered by the government, the cost growth is more predictable and can be managed through policy decisions and budget allocations. When a new technology or drug is introduced, the government has the power to negotiate prices and decide on its funding. In the U.S., the fragmentation of the system makes cost control a much more difficult and complex task. The lack of a single purchaser means there is no one entity with the power to negotiate prices across the board. The result is a system with high and often unpredictable cost growth. The Canadian system, for all its challenges, provides a more stable and predictable platform for managing long-term fiscal sustainability. The government can make difficult but necessary choices about resource allocation, a power that is diffuse and often thwarted in the U.S. system. This is a key reason why Canada's system, despite its lower spending, is often seen as more sustainable in the long run. It is a testament to the power of a centralized, publicly administered system. To understand the U.S. system fully, we must look at its major government programs, Medicare and Medicaid. Medicare is a federal program that provides health insurance for Americans age 65 and older, as well as some younger people with disabilities. It is a single-payer system, but only for a specific population, and it functions much like our Canadian system, with government-negotiated fees and coverage. Medicaid is a joint federal and state program that provides health coverage for low-income adults, children, and people with disabilities. The rules and eligibility for Medicaid vary by state, which adds another layer of complexity to the U.S. system. These programs are examples of public intervention in a market, but they do not create a unified national system. Instead, they create a multi-tiered system of care, where access and quality can vary significantly based on a person's age, income, and state of residence. This is a major contrast to the Canadian system, which aims to provide a unified level of care for all citizens. In Canada, a person's age or income does not determine their access to medically necessary services. This is a fundamental difference in philosophy. The U.S. system has public elements, but they are not universal and do not create a single, unified system of care. This is a critical distinction for understanding why the U.S. system, despite its public elements, struggles with issues of equity and access. In the U.S., health savings accounts, or HSAs, are a feature of some health plans, particularly high-deductible plans. They are tax-advantaged savings accounts that can be used to pay for medical expenses. The economic idea behind HSAs is to empower the consumer. The consumer has a direct financial incentive to shop around for care, compare prices, and negotiate with providers, much like they would for any other good or service. This is a key feature of consumer-driven healthcare. However, the economic consequences are not always as intended. The benefits of HSAs disproportionately accrue to high-income individuals who can afford to save and contribute to these accounts. Low-income individuals, who may live paycheck to paycheck, are less likely to have the funds to save in an HSA and may therefore be more burdened by a high-deductible plan. This is another example of a market-based solution that can exacerbate existing inequities. The Canadian system, by contrast, does not rely on individual savings accounts for medically necessary services. The system assumes a collective responsibility for healthcare, funded through taxation, rather than an individual responsibility for saving. This is a key philosophical difference that has profound economic and social consequences. The HSA model in the U.S. highlights the market's focus on individual responsibility, while the Canadian model highlights its focus on collective responsibility. To bring these concepts to life, let's consider a simple case scenario. Imagine two individuals, patient A in Canada and patient B in the U.S., both suffer a heart attack. Patient A, upon arriving at the hospital, is immediately stabilized and receives the necessary care. The patient does not need to worry about the cost of the ambulance, the emergency room visit, the surgery, or the hospital stay. Their only concern is their health. All financial transactions are handled by the provincial health ministry. Patient B, in the U.S., faces a very different situation. Their ambulance ride, emergency room visit, and surgery will generate a multitude of bills. If patient B has private insurance, they will need to ensure that the hospital and doctors are in network to avoid higher costs. They will also need to pay their deductible, copays, and co-insurance. The administrative burden and financial anxiety can be immense, even for those with good insurance. If patient B is uninsured, the situation is even more dire, as they will be responsible for the full, unregulated cost of care, which could lead to financial ruin. This case scenario is a powerful illustration of the real-world impact of the two systems. The Canadian system, by removing the financial barrier, allows the patient to focus solely on their recovery. The U.S. system, with its market-based approach, adds a layer of economic stress and complexity to what should be a purely medical event. This is the central argument for our system. It protects the patient from financial catastrophe in a way that the U.S. system does not. In conclusion, we have seen that the U.S. and Canadian healthcare systems represent two fundamentally different economic and social philosophies. The U.S. system is a complex, multi-payer model that relies on market forces, competition, and consumer choice. This leads to high spending, high administrative costs, and significant inequities, as evidenced by the large uninsured population and medical debt. The Canadian system, on the other hand, is a single-payer, publicly administered model that relies on central planning and collective responsibility. This leads to lower spending, higher administrative efficiency, and greater equity and universality, but often at the cost of longer wait times for certain services. Both systems face the same challenges of rising costs, an aging population, and new technologies. However, the mechanisms for addressing these challenges are vastly different. The U.S. system grapples with market failures like moral hazard and adverse selection, while the Canadian system grapples with managing supply and demand within a limited budget. A Canadian health manager must understand these differences to appreciate the strengths and weaknesses of our own system and to effectively navigate the policy debates of the future. The choice between these two models is not just an economic one, but a reflection of the nation's core values. Thank you for your attention.